Rita, you can knock your camera off.
Yes.
Okay. Okay, we will start the session in maybe 2 or 3 minutes.
Got a lot of people on already, so that's good. 82. Patrick, you guys recruiting at all?
Rita, I think everyone can hear you. So
Oh, okay, never mind. It's not for me, for my fellows.
We are. Gani, I'm not sure if you're still on there. I don't see the ability to put a question or put a comment in the chat to just let everybody know to put their questions and answers or questions in the Q&A session. I know if you could type that.
Yeah, I will do that.
Okay, perfect.
We have one.
Okay. Yeah, so it's 1:03 Central Time. I think we should start the session. I would kind of, on behalf of the organizing committee, I would like to welcome everyone to today's iteration of our neonatal hemodynamics collaborative webinars. At wherever you are in the world, welcome. I would like to start off first and welcome my co-moderator for the session today, Dr. Micah Bravo, who is a neonatologist at La Paz University Hospital in Madrid in Spain. It's actually quite interesting. You've got a Liverpool fan and a Madrid fan kind of on the same session today, and after the Champions League last year, that may not be a great idea. I don't know, but hopefully it'll work out. But Micah is one of the leaders in hemodynamics in Europe. She completed training with our good friend Nick Evans in Sydney and completed a PhD on treatment of the ductus in 2011, and has been actively involved in the European circles of hemodynamics and conducting prospective hemodynamics-based research. So welcome, Micah, to the session today. I would now like to just before introducing our speaker, just give a little bit of brief background as to why we chose the session today. To date, the vast majority of our kind of webinars have focused on specific diseases or controversies in neonatology, but one of the most common questions that I get asked when I give talks on the subject is about randomized trials in hemodynamics. Should there be a randomized trial of everything we do and so forth? And I think it's a very, very important subject matter to talk about and to actually look at, what have we done to date in the field of clinical trials? How has it helped us with our science? And as we move forward, how can we cultivate better hemodynamics driven clinical trials. And to address this topic, there's probably not many better people in the world than my good friend and former trainee in Toronto, Professor Afif EL-Khuffash. Afif completed a fellowship initially in neonatal cardiology at Our Lady's Children's Hospital in Crumlin in Dublin in Ireland, and went on to complete training, his neonatal specialty training in Toronto, and completed hemodynamics training and did a lot of kind of echo-based research during his fellowship in Toronto, after which he was appointed as an assistant professor of pediatrics at the University of Toronto in 2011. We failed to keep him in Toronto, and he was a huge loss to North America. But North America's loss is Europe's gain, and he's now back in Dublin and is one of the preeminent leaders in hemodynamics in Europe. Our collaborations have continued, and without any further claim, I would like to introduce Afif to take the floor and give us your thoughts, Afif, as to how do you think about trials, and where should we go?
Thank you very much, Patrick. Can everybody see my slides?
We just see you, Afif, and
you just see me?
Sure, we just see you at the moment. Yeah.
Oh yeah, 1 second. Sorry, I just need to share my screen. What about now?
Yeah.
Yes, now perfect.
Okay, well, thank you very much, Patrick, for inviting me. I'm honored to be speaking at this amazing endeavor. I'm actually coming to you from Kuwait at the moment. I'm on my vacation, but I wouldn't miss giving this talk, because I know Patrick knows where I live. So if I actually miss it, there'll be trouble. But I'm also very intrigued to speak about this topic, because this is something that I ponder a lot of the time during my clinical practice. Is there a role for RCTs in neonatal hemodynamic research? And I'm going to hopefully spend about half an hour discussing this. And I'm going to be broadly speaking about hypotension in general and patent ductus arteriosus. So I'm going to try and include both those topics in my discussions. So what I'm hoping to speak about today is, I suppose, recognize that the current approach to hypotension and PDA trials in premature infants have not really resulted in an improvement in outcome, and try and show you the heterogeneity of the underlying pathophysiology for low blood flow states in premature infants, and maybe work towards devising a physiology-based approach to the management of low blood flow states that can be tested in an RCT setting. I'm going to be quoting a couple of lines from Albert Einstein that I think really encapsulate the problems that we have encountered to date in terms of hemodynamic research in preterm infants. And sometimes I wish that Albert Einstein was a neonatologist. I think sometimes he wouldn't be in the mess that we are in. So what he says is that if he had an hour to solve a problem and that his life depended on the solution, I would spend the first 55 minutes determining the proper question to ask. For once I know the proper question, I could solve the problem in less than 5 minutes. And I think therein lies the problem in our approach to date, in that we really have not spent any time trying to either define or characterize the problem that we are trying to solve. We assign arbitrary solutions and test them randomly in an unselected population, hoping for an improvement. And, to date, this approach has been fruitless. So what do we know so far in terms of hypotension? Well, we know that, hypotension, no matter how you kind of define it, and I'll speak about that in a minute, but in this one was, the mean arterial pressure equivalent to the gestational age. We know that a low blood pressure is an independent risk factor for adverse outcome, including IVH and including mortality, especially if it occurs in the first 24 hours of life. However, what we have kind of demonstrated to date, I suppose, was that independent of whether you are hypotensive or not, giving antihypotensive medication is independently associated with an increased risk of death or adverse neurodevelopmental outcome at 2 years of age when controlling for risk factors known to affect survival and neurodevelopment. And when you dig deep into those studies that this review has sort of put together, the antihypotensive therapy I'm talking about is actually dopamine. Despite that, what we currently do is that we arbitrarily set a threshold under which we begin treatment. And the threshold that I'm talking about is the gestational age, the mean blood pressure equivalent to a gestational age. If the infant's mean blood pressure falls below this, regardless of anything else, we start treatment. And really, this threshold was set out in 1992 by a group of physicians that really had no basis for making this recommendation. It was set as a sort of guide or a baseline to consider treating an infant if a blood pressure approaches this threshold, but everybody has now taken it as a mantra of intervening when the mean blood pressure falls below the mean gestational age in millimeters of mercury. And this, unfortunately, has remained set in stone. And how do we approach it? Again, we try and keep things simple. We give a bolus, and then we give dopamine, and then we give dobutamine, and then we pray and give adrenaline and maybe noradrenaline and then dexamethasone and hope for the best. Really not thinking of the underlying physiological problem. We just have this regimented approach that unfortunately many centers still use in this day and age. And things are no better in terms of the duct. We know that in all the trials done to date, the definition of a hemodynamically significant duct remains elusive. Some studies, some trials only define it on clinical grounds. Some trials only define it on echocardiography grounds. And really, there is no definition that is set in stone. And when you look at the clinical and ultrasound parameters used for the definition of a hemodynamically significant patent ductus arteriosus, again, you see arbitrary cutoff assigned with no real thought or process done to it. So again, really no definition of the problem that we try to solve. And if I take you through the, I suppose, trials that have been done on inotropes to date, you see that they've included comparisons between either inotropes and volume, individual inotropes against each other, inotropes against steroids, inotropes against placebo, and sometimes lusitropes against placebo. Again, with no real thought in defining the problem. People are just thought, oh, let's see how dopamine compares to dobutamine and bringing up the blood pressure up. Oh, let's see how dobutamine fares against norepinephrine or epinephrine. Again, you know, many of those trials you see are all characterized by a couple of things. Number one, there are small numbers of enrolled patients, and these range from about 20 through to 90. All are underpowered to draw any short-term or long-term meaningful conclusions to direct clinical care. And again, this kind of mantra of intervening when the mean blood pressure falls below the mean gestational age, unfortunately, despite all of these trials, has remained set in stone. And the primary agent that we still use remains dopamine. We're very familiar with this approach, and as a result, it has rarely been challenged. And our desire to oversimplify and homogenize what is essentially a very heterogeneous, a very complex, multifaceted pathophysiological phenomenon has actually meant that 40 years on, we still do not have any concrete answers. The only thing we really know is that inotropes in general increase blood pressure if you give them when the blood pressure or the mean blood pressure falls below the gestational age. We still use a one-size-fits-all, and this has not only resulted in no improvement in the outcomes of these preterm infants, I actually firmly believe that this has resulted in harming a lot of infants. I was part of this very ambitious study, the hypotension in preterm infants randomized trial. It was a pragmatic trial, which originally aimed at enrolling 820 infants to see whether the use of dopamine in comparison to no intervention or placebo, when the blood pressure of an infant or the mean blood pressure of an infant falls below the gestational age in weeks, does that result in an improvement in outcome? Again, another example of trying to oversimplify the problem. The recruitment was near impossible, and we only ended up enrolling 58 infants, and we showed obviously no major difference in any of the outcomes because the study was significantly underpowered. The PDA in a nutshell is the same. A cause and effect relationship between a patent ductus arteriosus and important morbidities has not really been definitively established. And all the RCTs of prophylactic and early treatments to date have failed to demonstrate a reduction in important morbidities on long-term outcome. And Bill Bennett has done a systematic review, I think about 10 or 15 years ago, that he has recently updated and presented, demonstrating that even with the inclusion of the most recent trials, other than knowing that treatment of a duct results in an increased odds of closing that duct, with the exception of IVH, there really is no difference in any of the important morbidities you see. And the results are no different for trials selected by agent, indication, route, or age at treatment, use of rescue, year of trial, or subject to gestational age. So a very thorough systematic review that have resulted in, I suppose, the increasing notion that a PDA should be left alone. But again, I'm going to, I suppose, present two trials to you that provide an example of how these trials were really not set out to answer the problem that we want to ask. If you look at the biggest trial to date of PDA treatment, the TIP trial, I know it was really set out as a prophylactic trial. You could see here that in the placebo arm, 46% of infants ended up receiving ibuprofen, excuse me, ended up receiving indomethacin, sorry, within the first few days of age. So there was a high rate of open label treatment in infants that were meant to be in the control arm. And interestingly, this study that was recently published in the Journal of Pediatrics also, I suppose, demonstrates how poor we are at selecting infants that should be enrolled in PDA trials. This is a study that hypothesized that the early elimination of a PDA shunt, and I emphasize the term early elimination of a PDA shunt with ibuprofen, might improve long-term neurodevelopmental outcomes. They actually ended up with 3 groups. They had what they deemed to be a high-risk group that they used, I think, the PDA diameter to determine the high-risk group, and they randomized this group into treatment versus placebo. But they also had a low-risk reference group that they observed within the study. They randomized 228 infants, and they showed no difference in outcome between those that were treated and those that were not. And if you notice here, the rate of survival without cerebral palsy was 76% in the reference group. Now, if you look at the 2 intervention groups, the rate of survival without cerebral palsy occurred in 71% in the intervention group, 71% in the placebo group, and also 76% in the reference group. Now, if you are selecting a high-risk population and you randomize those for ductal treatment, and you compare those to a reference group that you deem low risk, the rate of survival in the low risk group should be much higher than in the randomized group, regardless of whether your intervention worked or not. So here's a clear example of how poor we are at selecting infants most likely to benefit from ductal treatment. The other thing I want to point out to you is that the the control group, open label treatment was allowed for pre-specified criteria. And when you dig deep into the study, you see that by day 14, PDA closure rate was 54% in the placebo arm, compared with 75% in the intervention arm and 64% in the non-randomized group. So you had three groups with broadly similar rates of ductal closure and broadly similar rates of the outcomes of interest. Therefore, you didn't really separate the high risk from the low risk group. And in your randomized group, your intervention did not work. And those that were destined to keep their duct open in the control arm did not. It is not surprising, therefore, that the rates of primary and secondary outcomes were similar between the groups. And it's important to stress that deciding that PDA treatment is futile based on these studies is unfounded. Another lovely quote I like from Albert Einstein, which unfortunately us in neonatology are guilty of: insanity, doing the same thing over and over again, expecting different results. We've been doing this for the last 40 years, doing the same trials, expecting something different. And I think, and I would actually state, that it is actually unethical to keep doing those trials in these vulnerable preterm infants without actually having or putting enough thought into first defining the problem. So in terms of the hypotension, we actually need to recognize that the premature infant has very unique myocardial characteristics. There's a dearth of contractile elements, and there's also a dearth of elastin, or the elements that promote adequate relaxation. Their contractility is very inefficient when you compare it to older children and healthier term infants. And as a result, the heart in the preterm infant is characterized by diastolic dysfunction, a dearth of adrenergic innervation and receptors, which means that inotropic effects overall are reduced, that the neonatal myocardium is poorly tolerant of increased afterload. So giving inotropes to these infants that raise systemic vascular resistance will end up in a reduction in cardiac output. And although you may raise the blood pressure because you are raising systemic vascular resistance, you may actually drop cardiac output and harming the infant. There's an overall resting peripheral vascular tone that is high because of the abundance of alpha receptors and the relative dearth of beta receptors. So the majority of agents that we give these infants have a net vasopressor effect, which is not good for them. Those infants have an immature hypothalamic pituitary axis. So there's downregulation of adrenergic receptors, and again, a lack of cortisol during stress. And of course, the left to right shunting, intra and extracardiac, can compound the problem. We also need to realize that blood pressure on its own is no reflection of adequate cellular metabolism, which actually depends on cardiac output, which is governed by heart rate, afterload, preload, contractility, and the relationship between all these components. It is also dependent on having adequate blood oxygen content, which is determined by how good they are at oxygen transfer and also hemoglobin. And we need to realize that cardiac output is difficult to measure. Systemic vascular resistance is difficult to measure. Therefore, we default to the product of these two components to make things simple. Our over-reliance on mean blood pressure, which to me is a meaningless number, should stop. We should give more emphasis to systolic blood pressure, which is a surrogate of cardiac output, and also diastolic blood pressure, which gives you an indication of systemic vascular resistance. We should disregard mean blood pressure and rely more on systolics and diastolics, and there are centiles that are actually there to guide you as to what the lower third systolic and diastolic centiles are for each gestational age bracket. So we need to define the problem better. The same goes for PDA. Hemodynamic significance is not just a function of ductal diameter. Yes, we need to appreciate shunt volume and try and measure pulmonary overcirculation and systemic hyperperfusion. We need better quantification of shunt volume, systemic steal, and pulmonary blood flow. We need to also incorporate how the heart adapts to this short circuiting of the blood. We need to incorporate measures of systolic and diastolic function in our definition of hemodynamic significance. We also need to take other clinical factors into the definition, including gestational age, antenatal risk factors, how premature the lungs are, and look into end organ perfusion. So the concept of hemodynamic significance is complex. It's a complex interaction between several intrinsic and extrinsic factors, making quantification of this concept a challenge. Shunt volume is hard to measure because it depends on so many different factors. Poiseuille's law actually governs flow through a tube, and it states that at a constant driving pressure, the flow rate of the liquid through the tube is directly proportional to the fourth power of the radius of the tube and inversely proportional to the length and viscosity of the tube. There's also the pressure gradient between on either side of the tube. So the length, the viscosity of the blood, the diameter of the radius, and the pressure gradient all determine shunt volume. And if you think about it in the context of a baby, all of these components actually change constantly. Blood viscosity changes over the first 24 hours, the diameter changes, the length changes, and the pressure gradient changes. So these kind of discrete single measures that we sometimes do are oversimplifying this by trying to equate shunt volume to the diameter of the duct is ludicrous. So hemodynamic significance is an amalgamation of all these components. We need to actually try and equate hemodynamic significance to important outcomes, try and establish whether there's a causal link between the two. And then once we do that, can we actually modify this course and improve outcomes? We did a study, it's about 7 years ago now, trying to come up with a way of predicting important morbidities in the setting of a duct. And when we tried to come up with a more robust definition of hemodynamic significance, incorporating heart function, incorporating gestation, looking at surrogate markers of pulmonary overcirculation, we found that ductal diameter is actually the least predictive. And when you look at ductal diameter in isolation, this is the gray dotted line, you see that ductal diameter is almost no difference to chance in determining the occurrence of chronic lung disease or death in these infants. So you might as well be flipping a coin to decide who warrants treatment and who's not. That's what we're doing when we randomize babies based on ductal diameter alone. So we need to use more robust measurements. So we need to use echocardiography. We also need to incorporate other modalities that can give you a more holistic overview of how the hemodynamic status of the baby is. So incorporating end organ flow, continuous cardiac output monitoring is essential because we need to try and break down the underlying pathophysiological problem into whether it's a preload, an afterload, a myocardial contractility issue, or a combination of the two. So then we can devise a more robust way of tackling the problem. So this regimented approach needs to be abandoned. We need to take a more holistic, more systematic approach in trying to, number one, accurately defining the problem and then going about treating it. The same goes for the duct. We need better surrogates. We need a better definition of hemodynamic significance. So I suppose that brings me to the question is, how do we do all of this in a trial setting? So over the next couple of slides, I will try and propose an approach in terms of RCTs in how we kind of manage the problem. So I propose that we need to consider broad inclusion criteria and not focus on and not exclude infants based on certain antenatal or postnatal risks. The diagnosis of hemodynamic compromise needs to be more robust. We need to more accurately diagnose hemodynamic compromise, not using blood pressure in isolation, but using a combination of maybe echocardiography and clinical characteristics. How do we randomize these infants? A big problem with the HIP trial was the short window that we had in trying to approach parents. And I've been involved in 2 other inotrope RCTs that failed because of the fact that we have a very short window to approach the parents. The problem with hypotension, the problem with any trial, I suppose, that involves using an inotrope is that you can't prepare for this antenatally. This is something that can occur, a couple of hours after delivery, 2 or 3 days after delivery, that warrants, I suppose, a quick treatment. So we're often approaching the parents at a very vulnerable state, trying to give them a heap of information and asking them to enroll their infants into trials. So we really need to start asking the question as to whether we can actually seek deferred consent in this. And I'd love to be able to discuss this once I finish talking to you. Maybe cluster randomization might work. And rather than randomizing babies to one inotrope based on the other, I think the way we need to randomize infants is the regimented protocol that a lot of us still use versus a more physiologic-based approach. So the volume followed by dopamine versus let's define the problem. Let's see whether this is a preload or an afterload issue and treat the baby appropriately. I think that's the only way we need to move forward. The evidence base for the physiologic approach is lacking, but there's a lot of observational studies. I know there's huge work done in Iowa demonstrating that this may be the way to go forward. We need to also consider rescue treatment options and factor in dropout rates. What outcomes do we measure? Well, I think we need to assess physiological parameters to make sure that, we are improving blood pressure, but we're also improving myocardial performance, for example. Are we improving end organ blood flow, regional oxygen saturations, the clinical parameters such as lactate and urine output? So we need to have, I suppose, an amalgamation of physiological factors that we need to measure. We also need to look at short-term outcomes and not just focus on the long-term outcomes. And we need to look at other things such as growth, duration of respiratory support, things that matter to parents, not just us neonatologists. Chronic lung disease, I hate this diagnosis because it dichotomizes a very diverse, heterogeneous disease state. So we need to come up with better definitions of our short-term outcomes. And I think we need to reserve our long-term outcomes to assure us of the safety of our approaches. Because, if you measure something 2 years after a baby is discharged, so much happens between the discharge of the baby and the time you measure neurodevelopmental outcome that any beneficial effect of the intervention you did for a brief period of time over the first couple of weeks of life for this infant will be diluted by a huge amount of environmental factors. So using a 2-year neurodevelopmental outcome to look at an effect, I think needs to be abandoned, and we need to use it as a safety measure. We need to better define ongoing respiratory morbidity, which I think is as important, and whether the baby requires ongoing community support or not. In the setting of a duct, we need to better define the problem and only select infants with a hemodynamically significant duct that are more likely to benefit from treatment. We need to ensure that our treatment actually results in ductal closure. So we need to develop more effective modes of administration or better dosing, whatever. But we need to actually work on improving the rates of closure in the intervention arm. And we need to ensure that those in the control arm maintain ductal patency. How do we do that? Twofold. First is that we select infants we know are unlikely to close their ducts spontaneously. And we have done a lot of work developing a scoring system that I think is good at predicting that. And also we need to ban open label treatment in any shape or form in order for us to truly test the effect of chronic exposure to the duct in a systematic manner. I've talked about the important outcomes to look at. I think the same applies in ductal trials. There's a lot of logistical challenges that we need to overcome as well. These kind of multinational, multi-site studies, they need a lot of collaboration. We need to ensure that we measure things the same way, we enroll the same, and that in terms of getting approvals in all different settings, we need to actually ensure that the interaction between agencies becomes more efficient. The provision of timely informed consent, I think, will remain a challenge in inotropic trials, and we need to seriously think about using deferred consent in this population. We also need to ensure that staffing is available to prepare whatever intervention we use in a blinded fashion on a 24-hour a day, 7-day-a-week basis. That's not always achievable, which means that we end up enrolling babies during the daytime, and we know that daytime babies are usually less sick than nighttime babies. So we need to ensure that we can enroll on a 24/7 basis. Final slide, I'm sure you're glad to hear. Current approach to trials of hemodynamic support have failed to identify the ideal methods of managing hemodynamic compromise. We've so far asked the wrong question, and we keep asking the wrong question and doing the same thing over and over and over again. Again, definition of insanity. We need to change how we approach such trials. We need to recognize the complex and unique nature of the cardiovascular system, the heterogeneous nature of the etiology, and we need to improve our understanding of the physiology and improve how we diagnose the problem, how we monitor the response, so that we can actually see whether our treatments work or not. Thank you for listening.
Thank you, Professor El-Khuffash, for your fantastic, clear presentation. And now, before going to the discussions that everyone is waiting for, let me introduce our panelist table. First, Dr. Anup Kateria is an associate professor of pediatrics and the director of the Neonatal Research Institute and the NICU follow-up clinic at Sharp Mary Beard Hospital for Women and Newborns. Dr. Kateria earned his BS in biology from the University of California, Los Angeles, his MD from Drexel University College of Medicine, completed his pediatric residency at Children's Hospital of Orange County, and his neonatal perinatal fellowship at the University of California, San Diego. He is the principal investigator for several trials. First, comparing cord milking to early cord clamping in term non-vigorous infants, MIMPI trial. Second, comparing delayed cord clamping at umbilical cord milking in preterm infants, PREMOD2 trial. Third, comparing early CPAP to early caffeine plus LISA, CALI trial in preterm infants. And lastly, comparing high versus low oxygen during delayed cord clamping in extremely preterm infants, the TOXI trial. Our second panelist is Professor Martin Klukow, that is a senior staff specialist in neonatology at Royal North Shore Hospital in Sydney, Australia, and a professor of neonatology at the University of Sydney. His research has centered around the physiology and transitional circulation of both term and preterm infants. He has particular interests in the patent ductus arteriosus, management of hypotension and pulmonary hypertension, umbilical cord clamping, time resuscitation, and point-of-care ultrasound, POCUS, training and accreditation. And he is the chair of the Australian-New Zealand Training Committee for POCUS. And finally, Dr. Rita Ryan is a physician scientist who studies neonatal lung biology and lung development. She has a special interest in bronchopulmonary dysplasia, hyperoxia, and surfactant biology. Her clinical research interests include infants feeding with need for G-tubes, feeding factor NEC, hyperbilirubinemia, and BPD associated with pulmonary hypertension. So please do not hesitate to write your questions in the Q&A chat. But before everyone write their questions, let me, Afif, ask you something, because what I have picked up from your presentation is that we have to deal with achieving the enough large sample size to have our results, but at the same time we need to have an homogeneous population trying to have multi-center randomized trials. So because you have said that from PDA perspective, the inclusion criteria can be using the score that you published to select the population of the infants that are not going to close the PDA. But I would like to hear your idea how to simplify to have the most homogeneous population to assess infants with circulatory insufficiency. From your point of view, how which are the minimum, but at least that cover all of them, biomarkers of circulatory insufficiency to include in the to have the inclusion criteria for these infants to randomize for inotropes?
Yeah, I mean, I think that's a good question. And the way I answer it is that I don't think we can simplify or homogenize infants that have circulatory problems, because, you know, the baby that is being born following an APH is not the same as an asphyxiated baby, for example. They may both present with the same blood pressure, but how we treat them is going to be completely different. So we need to accept that, you know, we're never going to be able to homogenize the population and oversimplify things. I think what we need to do is have a heterogeneous way of treating those babies. And that's what we need to test in RCTs going forward. You know, I think the way to do it is to randomize babies to the current most, I suppose, used method of treatment, which is, you know, give them volume, give them dopamine. That can be your control arm. And then randomize them to a more physiological based approach where you try and characterize the problem adequately and then institute treatment that treats the underlying physiology, be it, you know, low preload, high afterload, poor contractility, whatever. Now, I don't think that's an easy thing to do because it requires a lot of training. It requires agreement on how you actually, what are the entry criteria? You know, there must be a way of screening those babies from a clinical sense to say, okay, you're potentially eligible. So that's I suppose is a definition that we need to kind of agree on, is how you actually define hemodynamic compromise in a way to enroll them in the trials. So, you know, I'd be open to suggestions, because I don't think it's not a simple answer, but it should be a combination of blood pressure and not you know, mean blood pressure, but even if, for example, we could look at systolic and diastolic you know, thresholds, taking the antenatal history into consideration as well. You know, for example, an infant born following huge APH, you know, that baby would be enrolled in the study. Potentially asphyxiated infant with a low pH can be enrolled in the study. Patrick may, I suppose, allude to this, because I know they have a hemodynamic approach in Iowa that targets these babies. Whether you screen everybody and then randomize based on universal screening, plus, you know, clinical markers, plus antenatal history pointers, is kind of one way of doing it. So, you know, I don't think there's a simple answer to that yet, but I suppose we need to better identify infants that would be eligible.
So let me build on that and maybe kind of, you know, open it up to the other members of the panel as well. I think I think what you've told us in your talks is that when we look across the spectrum of problems that we face in the NICU, based on the research that's been conducted and trials that have been done, we've not found a path forward that's very, very clear. And at the same time, we're trying to balance within the NICU a situation whereby to the clinician, they only have access to certain metrics and simple metrics. And very much the paradigm has been driven by trying to solve the problem by treating the symptoms, as opposed to what do the symptoms mean and how does that vary? And my question to the panel really is, how do we, change the needle from that perspective, to try to better study this variance in phenotypes that may exist across the board. I sometimes get asked the question, should there be an RCT of echo in the hands of a neonatologist versus not? And it's a very hard question to answer, because the counter viewpoint is human infallibility, that in our hands, examining the baby, we know everything, which we also know is not true, and so forth. So kind of, what do we think? Martin, what do you think about, kind of how do we change perspectives? Because people want it to be easy, but I think what we're hearing is not easy. It's complicated stuff, and we need to try to move beyond that simplicity.
Thanks, Patrick, and thanks, Afif, for a thought-provoking talk, as always. I think, as everybody's pointed out, and I think we're the realisation that hemodynamics is by its very nature variable, heterogeneous, and trying to enrol patients into trials without understanding that variability, that physiological variability, is problematic. And I think that's where, as Afif has pointed out, we've run into trouble, because we haven't recognised or spent time understanding the population of interest, and therefore, and then when we get to the point of actually randomising babies, what we'd like to see is that we've got the group of babies who are most likely to respond to the particular therapy that we're interested in included in the trials. Otherwise, we have dilution of our effect. We have randomisation by its very nature. If we don't pre-specify or understand our groups, is going to result in an average effect. Some babies benefit, some babies no difference, some babies harm. But at the end of it, when we analyse our trial, we end up with no effect. And I think, Afif's been pointing that out quite clearly in his talks today and in other publications, that this is something that we need to pay attention to. So the question is, how do we do that? And a randomised trial of ultrasound, I agree with you, Patrick, is going to be difficult for a whole lot of reasons. And I think we need to break it down to be a bit more specific than that. And I think we need to invest more time in understanding our patients before we randomise them, and maybe a little bit less time and money in long-term follow-up, because I'm not sure that's the end point that's most useful in hemodynamics. And Afif's already pointed out the difficulties with dilution of effect over an 18-month or 2-year time frame. So if we can spend more time identifying our physiological subgroups, I think that is going to eventually pay us back in terms of getting good and more consistent outcomes. So I'll leave it at that. I'm happy to talk a little bit more on some of the issues around randomised controlled trials and whether they're useful in the neonatal period, particularly in our hemodynamic babies with hemodynamic abnormalities. But I think I'd be very interested to hear from Anoop, for example, about, he's clearly one of the leaders in doing clinical trials, randomised clinical trials, and the issues that you come across, Anoop. And are we getting the full population, for example? I think that's, or is it just the low-lying fruit who don't have much of a response? So those questions, I think, before we undertake trials, we need to understand how we enrol the total population. So I'll leave it there.
Yeah, so Anoop, I think same, maybe you can build upon that. I'd also like to hear Rita's point of view as well, as a non-hemodynamics person, but someone who truly believes in science and so forth.
Yeah, so I'm glad you mentioned that, Patrick, and I'm glad, I think Martin kind of took us back a little bit to the title of this session. So when I first saw the title, is there a role for randomized controlled trials in hemodynamics? I didn't know where you guys were going to end up on this. So I was a little worried for a second. So I'm glad the answer isn't, we're just going to give up, right? Because that is an unacceptable answer. And I think the idea of trying to do a better job, and how can we do a better job? And one of the things I'd like to get back to after I give you my other comments is this idea about the deferred consent. But I wanted to mention that on the HIP trial, Afif, that you were part of, that Gene Dempsey ran, that study was chosen by one of my fellows for the journal club motif that's done by Journal of Perinatology. So we have a little write-up coming out about this. I hope nobody will be mad at us, because yes, the study was underpowered, but we subtitled our EBM lesson something along the lines of when perfection is the enemy of the good. And I think we all fall into this trap, especially with, I haven't done hemodynamics trials, but I've done a lot of ventilator studies, and you try to make the perfect study and then you can't enroll anybody. So I think learning the lessons of sometimes you have to be a little broader in your criteria to make sure you have enough patients. And then we can argue about, who should be in the study and that sort of thing. And then the third thing I'd like to comment on is the long-term outcome stuff. Even though I totally agree about the dilution effect and that so many things can happen, but especially for the hemodynamics people, we now know that there are so many things that we're doing that are affecting people when they're 50, let alone at 2 years of age. So I don't think, particularly in the cardiovascular area, I don't think you can completely say, well, it's going to be dilutional if they smoke, if they there are important things to learn that we still don't really understand at all. So those are my kind of big picture points. And Afif, I don't know how you managed to put that into 35 minutes. It was fantastic.
Oh, thank you. So I suppose maybe I wasn't, and I apologize if I wasn't clear. I wasn't dismissing the 2-year developmental outcome, but I think what I was trying to emphasize was that we should reserve it to make sure we're not overtly harming these individuals or these babies that we enroll, rather than use it as a primary outcome. I think we should still use it as a safety net to make sure that we're not actually, because if you demonstrate harm at 2 years, you know that whatever you did back when the baby was in the hospital was pretty bad. So I think we should sort of reserve it, maybe shift the focus to it being a safety outcome rather than a primary outcome we try and modify with a single intervention. That's what I was getting
I don't
at.
know why we in neonatology feel this compelling need to have such a broad outcome for all of our studies. It used to be when we first started looking at surfactant, if the oxygen went up, people said, wow, this is probably doing something important. And then the FDA required a decrease in mortality outcome. So, if a cardiologist thinks adductus is a problem and that there's a big left to right shunt, there haven't been a million randomized controlled trials to show that that's beneficial. They just close the ductus, right? Or they give Lasix whenever they want to give Lasix. We can't give Lasix because there's no randomized controlled trial saying we should give Lasix. But if the baby looks puffy and he's gaining a lot of weight, sometimes it maybe is a good idea to give Lasix. I don't know where we got this idea that every single thing has to be done by randomized controlled trial. I mean, certainly very dangerous things and very expensive things probably should be studied. And I'm not against studying anything, actually. So I'm glad you guys are coming down. I think you're coming down on the side of that we have to find a better way to do the studies. Not that we're just going to give up because it's so difficult and we have so many negative results and that sort of thing.
So maybe, Anoop, do you want to we take that and as a person who has successfully completed trials, kind of what lessons have you learned, and kind of what would be your words of wisdom in trying to do this better?
Yeah, no, thanks. And I think that was a great talk. So I love this topic. And one of I think the biggest secrets or the dirty secrets of people that participate in trials is we bias and we select better patients. Nobody wants to fill out forms of babies who are doing poorly. And honestly, I think that's when we're looking at a lot of these studies, the PDA trials and others, we're just not seeing it. And it's a lot of it is about patient selection. And just to touch a little bit on waiver, we've had some good success using waiver trials, at least in the US, which compared to other countries, we're a little bit behind. But the cluster crossover design is great. We just released our paper on milking a few days ago, and 97% of the babies who were eligible were in the trial automatic, no questions asked. And I think the idea of, to me, using echo, just getting back to, I think, one of the things that I've talked about with Patrick and others is that, we're great at publishing and looking at these case cohorts or case reports that, echo did well on this baby, and Martin and I have talked about the N of 1, like every baby's different. Well, that's where the perfect situation of using early focused hemodynamics. I mean, we have so much more resolution than NIRS, but they've been able to conduct SAFU saying if your NIRS is low, here are 10 different things to do. It actually makes even more sense to apply the same thing for using echo. So we're not sitting here 5-10 years later saying, yeah, there's a select of us and these 200 plus people on the call, maybe they're all pro echo and they're using it in their unit. But the rest of the neonatal community is sort of like, yeah, I'll get my echo when I think there's a duct and I'll treat it. They're not looking at this kind of holistic approach of how to do, a targeted approach for whether even not to treat a patient. And so there's lots of ideas of way we can do this. And I think, Patrick's put together this nice group from the Hemodynamic Collaborative. And I think we need to get enough people in here that are willing to go out there and get funding. Using a cluster approach allows you to use waivers. So you don't have to frantically run and consent a mom about using, pressors or not, or doing an echo or not on a child. And I do think more and more people are understanding that we're doing research at disservice by only consenting certain families and not others. We know time and time again, babies who are not in trials do more poorly. And so I think as we're pushing this ethics envelope and saying, if we want to answer this question, make this data count, we have to be able to get everybody in it. So the idea of variability is great. And that's where I think ECHO is perfectly designed to pick and choose the babies who are sick or not sick, the babies who don't need that low blood pressure treated, or maybe just need their duct treated and their blood pressure will be fine. And I think someone needs to do this study, or collaboratively, maybe multinationally, we all sort of go to our respective agencies and get some funding to do a trial. So I'm glad.
Anu, can you talk a little bit more about the waiver of consent thing? So your IRB, that was okay, they didn't give you a hard time about it?
So we just finished our, we had 10 centers that all got independent waiver. This is before the NIH mandate of central IRBs. So we lucked out on that. But I'm actually talking to a few central IRBs to do this. A cluster crossover design by nature has to be able to include every potential baby. If you select some babies in one period and not the other, it becomes a moot point. And again, it's all about risk, defining risk. In neonatology, you have to have IRBs that understand premature babies will die, will have IVH, et cetera. Does your intervention increase the risk above baseline? And if you could talk about what current practices in the interventions that you're using, again, we've had plenty of people saying ECHO, putting a probe on a baby done properly does not increase the risk of that baby having, adverse outcomes, et cetera, compared to all the other approaches we're doing. If you can convince that to an IRB, convince that to parent groups, and we've done a lot of things with parent advisory boards at different centers, there are ways to do that. And I think, there are a lot of champions in other areas of the US that Matt in Texas has been doing some great work. There's a few others, in the NRN that are looking at these questions too. So I think we need to catch up. Really, Martin's group and those in Australia are probably the most ahead. They have almost every trial has almost a waiverable component to it. And I think we need to apply that to hemodynamics. I don't think we've done a great job in our field doing that.
I think Micah has a
Yeah.
question. I think there's a number of questions from the chat, and I'm going to focus really on the one that really talks about what we are speaking today rather than specifics of treatment.
Yes, there is a question that said, given the current lack of the evidence, do you think Afif and the rest of the panelists, you can give your opinion also, that the first step, should we only focus on mechanistic randomized clinical trials in neonatal hemodynamics to establish that the proposed physiologic-based treatment approaches achieve the desired physiologic endpoints? And after that, we can move on to the larger randomized trials to achieve clinical endpoints?
Yeah, thanks, Shulik, for that question. Yeah, I actually fully agree. I think it's part of defining the problem. The mechanistic studies are extremely important, because if we are treating based on underlying physiology, we need to first demonstrate, are we correcting the underlying pathophysiology? And then we can then go on to see, is this correction resulting in an improvement in outcome? I think missing the middle piece is part of the problem, that we give a treatment looking for a clinical response without actually truly studying the underlying physiological impact of that treatment. That's what we're lacking, and that's what we need to work on. So I think that's a very valid point. And just to kind of give you an example, we just finished a a longitudinal study of infants with Down syndrome, and we've demonstrated that we followed 70 infants with Down syndrome up to 2 years of age, and demonstrated that universally they have elevated pulmonary vascular resistance that persists up to 2 years of age, independent of congenital heart disease. Now, we know that the pulmonary hypertension results in an increased risk for ECMO, hospital admissions with respiratory tract infections and whatnot. But what I want to do next is I want to see whether the administration of a drug, for example, sildenafil, in this population can result in a change in the PVR trajectory in these infants first, before looking at whether giving sildenafil improves clinical outcome. Because I think it's important to see, yes, I've defined a problem now. Can I actually reverse this physiological problem that I identified? And then I go on in a larger setting to see whether the improvement in the underlying pathophysiology, does it actually result in an improved outcome, whatever that clinical outcome is. So I think these are the baby steps that we need to do. And sometimes we get impatient. We want to do this big funded study, randomize as many babies as we can, without really seeing, does our therapy actually result in a reversal of the pathophysiology first? So yes, a short answer is yes, I think so.
Any other thoughts on?
There's probably more room in the basic world also for some of those mechanistic things. Do certain babies have more or less receptors for a certain kind of medicine that could make a different response? And those kind of, we really know very little about that. Just making a plug for that too.
Absolutely.
The other things that you touched on, there's some other really important things in your talk, which I think we need to address. Open label treatment. I mean, you're very strong on that we should ban open label treatment, but it's not as easy as it sounds. And you really need a commitment up front from clinicians and yourself too, that you're going to be able to tolerate a left to right shunt in the first few days without doing any treatment. And I've had at least one baby who's died with a large left to right shunt, who's in a trial of where we'd signed up to no open label treatment. And I felt really bad after that, because it was just an individual case, but you have to face up to that if you randomize babies in that and use that as strictly as you've said, as to ban it. So we've talked about patient selection, open label treatment. The other thing which you also touched on, which we need to do more work on, is the efficacy of our treatments and understanding. Because at the moment we give a non-steroidal, for example, and then we assume that in our analysis that results in ductal closure, but we all know that that doesn't happen. In the other arm, we've got babies who are in the placebo group who close their ducts spontaneously. So that that particular problem that we have with the ductal arteriosus and sorting out those different groups is also very important. We need an approach to that, and I think you've given us some suggestions how we might do that.
Although the example you picked for the banning of the open label thing was a study that actually was a prophylaxis study. So treatment for the problem later was actually one of their outcomes. And I didn't object to that so much. It doesn't help you with the long-term outcomes, but for that particular study, is prophylaxis useful? It made sense that that was an okay thing for them to do. But yeah, I agree.
Fair.
I agree. You have to have equipoise, and I have equipoise for all of these things. And it's hard. It's hard.
Sorry. Just on the efficacy piece, I think trialists look away now, because when we did our, I suppose, subgroup analysis of our small PDA study, we actually found that in the intervention arm, infants that we treated, but we did not achieve the desired outcome of ductal closure, actually fared the absolute worst out of all the other subgroups. And I think what you're getting here is that you're exposing a child to all the potential side effects and adverse effects of the drug without the efficacy piece. So these are the most at-risk population. So I think Rita's point is very important, in that we need to actually work out which babies are likely to benefit from treatment in terms of getting the desired effect. Because if you give a treatment and you don't get the effect, you're only exposing the child to the side effects of that medication. Because I think that's something we need to work on. So babies that don't respond to treatment, I think, fare the worst, because all the drugs that we use will have undesirable effects. So it's a balance of achieving the desirable effects over the undesirables. And if babies don't get the desirable effect, they're just exposed to the side effects.
Can I hone in on just a couple of things here? We've got about 10 minutes to go on the presentation. I'm going to say something very radical, just to make a point, because I think it's good for the discussion. But recently, at the PDA symposium, we were talking about this topic of a patient selection. And I drew the analogy to, let's say, an adult, and you have a lesion on your skin. Who would be prepared to be randomized to chemotherapy versus not, without ensuring that this is a true pathological diagnosis of something that is malignant or is a cancer? We would all say that's crazy to actually do that. So now, building on Anoop's comment about, that we actually could do trials with echo. One of the questions I have for the group here is, in doing those type of trials, then how do we standardize to ensure that the use of the technology is consistent in those trials? I think some of us have learned the hard way that sometimes you do echo-based trials and the data that you get sometimes is not as clean, maybe as what you would hoped for the selection part. That's my first question. And my second question, and I think, Rita, this goes into your world, is that the vast majority of trials of hemodynamic interventions have used BPD as an endpoint, which is not a pathophysiologic diagnosis. It's actually you're receiving treatment for something, which could be BPD or could be something else. So on those two fronts, how can we do better? So I know, Anoop, if you want to start off.
Yeah,
with
he can take the first one. I'll take the
First,
second
yeah,
one. Let's not pick on BPD now. Come on.
Yeah.
I'll give you the second question, Rita. I think the first one, it's a great one. The challenge right now we have with this designing a trial with echo as the intervention, or an echo-based or targeted-based approach, is you have centers like Patrick who have no equipoise. They would absolutely never not do an echo in a 23, 24 weeker in the first 12 to 24 hours of life. That is so routine in their group that there's no equipoise. Then you have some centers like mine where you might, and I think that's the majority, where you might have one or two people that are the only ones in the group doing early targeted echo on their babies or when they're in the unit, et cetera. And the rest of the group, just looks at the blood pressure. And I think the question is, can you, one, vet enough people that like, as Patrick is saying, that are standard in their approach? One of the challenges of Afif too in your talk is, well, how much of this sort of new, I haven't quite evolved to using all the advanced hemodynamics at the bedside, but you make a great case that there's plenty of other measures that need to be sort of incorporated in this, but then you might have to hone that down to something that still becomes enough where we all feel comfortable with the measures that are being done at 10 different sites. So those are logistical things, Patrick, but I don't think that should be the nail in the coffin. Oh, we can't do this. And I think we've been talking about this long enough. It's time that we start really embarking on it. So I'll turn it over to Rita.
So I think from the outcome standpoint, it is important. And actually, Afif, when you brought up the Down syndrome sildenafil study, it is important to say what is broken that we're trying to fix. So if you guys think that some kind of neonatal hemodynamics and intervention in badness or goodness there is going to make BPD better, then I'm all for looking at that. Somebody said something about BPD is so heterogeneous, which it is, and it's a yes/no heterogeneous. Of course, there are ordered diagnoses as well now, as you know, but so is asthma and so is diabetes. These are big, broad diagnoses that have people that are very, very sick and not hardly sick at all. So that isn't, that impossible to look at or understand. And I'm all for improving BPD. And so, if you guys think that that is a good outcome, then that's fine. But our kids are so complicated. When you say what is broken that we're trying to fix, I think the answer usually is neurodevelopmental outcome. And there's a lot of pathways to that outcome. So it's very complex. And BPD is part of that. And so is hypotension in the early few days and IVH. They're all kind of in there. So it is very complicated what you guys are trying to tackle. And I'm all for targeted neonatal echo. I'm just too old to learn how to do it. I wish I was younger because I would have done it. I just don't have that brain that you guys have to look at it like that. But I think it's really important.
Rita, I think what I was trying to get at it, under the umbrella of BPD, what we're learning now is you have some babies that have lung disease with pulmonary hypertension, without pulmonary hypertension. Some babies whose lung disease may actually not be exclusively primary lung, but maybe there's an issue with the left ventricle and a post-capillary type. It's actually a very complicated disease that we're starting to better understand. And how do we kind of integrate that also into choosing, the best outcomes? I'm curious to know from the others, Afif, Martin, with respect to the standardization of imaging, and kind of what are your thoughts on how feasible is that? And certainly in the United States, it's probably the worst place to start with, because, you know, a lot of places are kind of, I would say, kind of at the mercy of having to be reliant on another department to provide echoes. And will you get the standard or the detail? The detail
If
is
you have
probably
money, you can buy
Yeah.
them and they'll do
Yeah.
it for you.
Yeah, but the detail, and we don't always get the measurements you need, which I think is another question. It's for that reason, you know, I got to put a plug in for Pivotal, Carl Back's trial of cath closure. What that trial has introduced is that every baby prior to randomization will have their echoes read at a central echo core to ensure that the patients truly meet a hemodynamically significant PDA. That's the starting point. I think that's brilliant. And I think that's kind of the future of where we need to go with this type of stuff. But anyway, I don't want to do all the talking. Afif, Martin, anything you guys want to add?
Yeah, I mean, it's difficult because there's different approaches to echo in different jurisdictions, but I actually do think that there should be a standardized approach to how you make a hemodynamic assessment, because that really is the only way in paving the way to kind of define the problems at hand. Because if people are doing things differently, you're going to end up with different definitions for similar conditions. So I think we need to, first of all, agree on a uniform approach to acquiring the images or the data, and have agreeing on the thresholds for what defines normality and what is not normal. So again, these are all things that we are trying to do. And Patrick, you're part of, you know, the kind of, I suppose, the new pulmonary hypertension registry in Europe that we're trying to actually come up with a diagnosis of pulmonary hypertension in both term and preterm infants in the neonatal period. We don't even have that. You know, so there's a lot to do here, but I think standardizing the approach is the first step.
Just building on that, I think standardization comes through training and accreditation as well. So that training and accreditation program is very important, and there's been a lot of progress made in that over the last few years, particularly in North America, but all around the world as well. We're all gradually improving our training and accreditation process. The other thing is, it gets back to what point I made earlier, is that I think we need to spend more time and by implication funding on understanding our population and the population of interest. And that may involve, for example, sonographers and people who actually can come and actually provide a standardized set of measurements for us. It doesn't necessarily have to be us as the clinicians with all the variabilities that we may bring. So I think that speaks to the fact that when we get funded for a trial, we maybe should be looking at getting funding up front for proper assessment of a baby hemodynamically in a more using a subset of people who are actually specifically for collecting the data, rather than us who are the jack of all trades and are designing the trial. Then we're actually getting the information as well. So we're starting to look at that a bit more as to whether we should include that in the funding of our studies to get that more standardized specific information.
But I think you guys have all brought up some great points that in our zeal to get clinical trials started, we are not paying as good attention as we could to picking the right patients. What are the mechanisms, you know, slowing down a little bit and thinking about that, and maybe reaching out to other people and getting their input before you just plow headlong into, well, let me get my first 100 patients enrolled, you know, and then before you know it, you're not even doing the right study.
Okay, so I think we're just about time to wrap up. I'm gonna maybe have Mike.
Yes. Yes, I have only to say that thank you very much to all of you, especially to Professor EL-Khuffash for the great presentation that he has done, and all the thoughts that has been pointed that are really important in our work, in our daily work, and hopefully we can do more collaborative research in order to have the outcomes that we need to improve the survival of our preterm infants. So thank you very much, all of you, and also all the people that have followed, that I think that has reached almost 300 or close, very close of that. So It's amazing. And thank you. And hopefully we can see in other webinars. Thank you so much.
Great to see everybody.
Thank you, everybody.
Thank you, everyone. Thanks very much.
No, thank you, Afif. And I'm particularly, I'm really pleased with the, the attendance. I think you should be very proud of getting 300 people for this, which very much was a philosophical talk rather than actually a disease-driven type of talk. So well done. And
It's great.
Martin, thank you so
Thank
much
you
for
so
getting
much.
up so early in the morning. I
Yeah.
really
It's
Yes.
a great topic.
Thank-
Great. I wouldn't have missed it. Thank you. Very
Martin
interesting.
and I talk at all sorts of crazy hours all the time, particularly with this book.
That's right.
Okay.
Nice
Thank
to
you.
see everybody.
Bye-bye.
See everyone.
you.
Bye-bye.
Nice to see
Bye-bye.
you.
Great job.
Bye-bye.
See you later.